Good afternoon, and thank you for joining us today. My name is Mike Whitmer. I'm Vice President of NCMIC's Chiropractic Insurance Programs, and I'm your host for today's webinar. Before we get started, there are a few housekeeping items I'd like to review. All listeners are on mute. If you have questions, please enter them in the questions feature on the GoToWebinar menu. We're going to address questions at the end of the webinar as time allows. If we don't get to your question, please feel free to contact us and we'll be happy to talk with you and connect you with resources to help. Today's webinar is being recorded. The recording will be emailed to you a couple hours after the program. It does take a little bit of time to process the recording and get it posted, and we appreciate your patience. Our goal is to post yet this afternoon. I'd like to talk with you, tell you about our next webinar scheduled for April 15th at 12:30 p.m. Central Time. We're going to be talking with Dr. Kelly Humphreys about sports chiropractic. Dr. Humphreys has great experience in this area, and I'm really excited to talk with her. I hope you'll be able to join us. Now for today's program. It's my pleasure to introduce you to Dr. Stephen Gould. Dr. Gould is a board-certified chiropractic radiologist who became a diplomate of the American Chiropractic Board of Radiology, or DACBAR, in 1993. He has full-time radiology and clinical patient practice where he performs interpretations of plain film, radiographs, and MRIs for referring chiropractors. In his clinical practice, he has provided chiropractic care to the Wichita Wranglers professional baseball team and the Wichita Thunder hockey team. He's been active with the Kansas Chiropractic Association, earning the honors of Young Doctor of the Year in 1994 and Kansas Doctor of the Year in 2012. Dr. Gould has also served as a member of the Kansas State Board of Healing Arts and served a term as board president from 2019 to 2020. Dr. Gould, welcome to our webinar. We're excited to have you with us today, and we're looking forward to your program. Now I'm going to switch so that you can share your screen, and then we'll get started. Okay, you should be able to share your screen now.
All right, and you can hear me okay?
We can hear you fine, thank you.
Thank you, Mike. Great introduction there. And get going with slides. And you're okay with that so
Looks
far?
Good. Looks good. Yep.
And I go to this. Okay, so
looks like you're
yeah,
good to
thanks
go.
for the introduction. And we'll get going here. Two cases in chiropractic imaging, kind of surprise on the diagnoses or origins of their pain from these cases. And I guess we'll just get going and go through them. So they remind us to do our own work when we have a patient come into our office, even though they might have been to another provider. And good history and examination should elucidate as much information to allow us to arrive at a diagnosis prior to treatment or referral if it's not something amenable to our type of treatment. And there are situations that imaging, of course, will disclose findings that might change our initial impression and our final diagnosis. And then decisions to obtain imaging must be based on our history and exam findings. And of course, there are some guidelines out there that we won't discuss a lot of, but we want to pay attention to the patient's findings and go from there. So our first case, 8-year-old female, came in with low back pain of 8 or 9 months duration, and she cannot run, she can barely walk quickly. Constant pain is described. The mother described that she was kind of a little blue ribbon gymnast before this pain started 8 or 9 months prior, and now she's not able to perform gymnastics, and they had to cancel her gymnastics classes. And she's been receiving monthly, or actually I think it was actually bi-monthly, osteopathic manipulation treatments from their pediatrician. And I also forgot that they'd had arch supports placed, and she had pes planus and mild pronation, so they had arch supports, and that's actually how this patient got referred into me, was from a podiatrist. And anyway, so no imaging has been done yet. The mother does tell us that she had been seen at a large hospital up in Kansas City regarding this pain, and they diagnosed her with Sjogren syndrome. And then with her pes planus and pronation of her feet and ankles, they also diagnosed her with a hypermobility syndrome. And that was through a rheumatology clinic up there. So no spinal or x-rays were obtained, even though she's got this back pain. But they did mention that someone did hip and knee x-rays on her, but we haven't seen those, or had never seen those. She can't run again due to the back pain, visible gait changes. We take her in the hallway and watch her walk. And she could not get up in too much pain to actually run. She could kind of get a faster paced walk, but she was protecting her spine when she was walking. It almost looked like she had adductor muscle spasms because her knees were kind of pulling together in that protected gait. And of course, our exam revealed a painful range of motion in all movements, a positive hop test. And I don't know, there is an orthopedic name for this, but I haven't discovered it, and it doesn't really, the name of that test escapes me right now, but it also doesn't describe what we look for in the hop test. But kids with spondylolysis, active spondylolisthesis, I think someone with an acute compression fracture, if you have them raise up on their tiptoes and drop down hard on their heels, that should not be painful. Or you can actually have them just hop in place and get their feet up off the ground and land on their heels. And again, that should not be painful. And in this case, it was markedly painful at the lumbosacral junction. And on palpation, when we put her on her tummy and palpate the lumbosacral junction, especially over the right side of the junction and superior sacral area, that was crying level pain. And so she was not having fun on the exam table at that time. She can't perform fast walking without limping gait. All of her muscle strength was fine, no sensory losses in the legs, and her deep tendon reflexes were graded normal as well. So due to her continued pain, painful range of motion, and her walking difficulties, we obtained lumbar spine radiographs on her. And her clinical symptoms and the way she presents with the hop test and the location of her pain is similar to our teenagers we see in sport with spondylolysis or posterior arch stress reactions. And so that's another good reason to get films on her. Of course, x-rays are not real sensitive for early spondylolysis. And she, being only 8 years old, is a lot younger than most of our adolescents that come in with spondylolysis from our sports practice. And so that was kind of puzzling that she was so young to present with this type of pain, although very similar to what the sports kids with spondylolysis present with. Ponytail holder artifact got me there. So otherwise, her 2-view lumbar study, no evidence of spondylolysis or spondylolisthesis there. I don't know if I can get a pointer up here, but all the vertebrae line up the way they should. And we just have an increase in density in the S1 segment here. And then we can't see the good cortex to the top of the sacral ala. On this one, on the AP image, is that bowel gas, bowel content pattern overlying that region. It's just not real clearly seen. But this density, I think, is real here. And so we went on further and ordered, I guess that won't let me click without doing, there we go. And so there's our findings, of course, our bowel gas pattern over that right sacral alar region. So MRI ordered for further evaluation of the marrow, and also to help, again, rule out stress reaction. So the lumbar MRI, and really in hindsight, probably should have ordered a pelvis, or a lot of times we might have to do a lumbar spine and a pelvis, because where they put the coil on the patient for the MRI study, it's body region specific, and so we'll have to do a 2-area study. If you're trying to look at that top of the sacrum or the sacroiliac joints, you're going to have to get a pelvis and not a lumbar spine. But this is a non-contrast lumbar spine examination, fast spin echo T2 image here on the left, and a T1 weighted image on the right. And so we can see the marrow change in the vertebral body of L5 here, or the S1 segment here. And no soft tissue mass in front of it, but it does change the cortex, and we've got inhomogeneous signal within the marrow here. Inversion recovery image, again, it's not really bright white, so it's not a big fluid mass, and there might be some material coming posteriorly there into the canal. And then we've got some axial images. And so the normal sacral ala on the left, and then we have the involved sacral ala on the right with the expansion here and the change in signal intensity of the marrow, and that correlates with that ill-defined region on the plain film. And there's another slice lower. So again, we can see the altered morphology of the sacral ala and the kind of mostly, it's inhomogeneous, but mostly intermediate signal intensity within the marrow. So we told the family that the evening after the MRI was performed, I called the family and let them know that we had some findings on there. Couldn't tell if it was an infection or what it exactly was, but we needed to get, they have United Healthcare insurance, so they had to have their medical doc make the referral for anything else. And I told them, well, if she's in pain, a lot of pain, then go ahead and take her to the ER. And actually what they ended up doing that night, she was so painful in bed rolling over after the MRI study was performed that they went ahead and took her to the ER, and they gave her some pain meds, and they also did CT. So here's a coronal reformatted image of the pelvis here, and then I've got a few slices in a row to share with you just to see how that walks through with that destruction of the bone at the right sacral ala. And of course, anything walking or weight bearing is going to really bother that. So here's a few more slices coming through there. So clinical differentials, of course, strain of the lumbar spine could have been considered. That's a pretty long time frame for a strain. Active posterior arch stress reaction. Again, if it's an older teenager, we think, that would be a good possibility for this type of pain pattern. And then, of course, our osseous pathology due to the appearance of the radiographs in the sacrum. And then we go into differential diagnoses like on the MRI with the chordoma, chondrosarcoma, Ewing sarcoma, osteosarcoma, and fibrous dysplasia, just thrown in there as a copy or mimicker of everything. But spondylolysis and spondylolisthesis in the adolescent athlete, of course, as I mentioned, this person's younger than our usual adolescent athletes are, so it's not, I just haven't seen a acute spondy or active spondy in a kid this age yet. So the posterior arch stress reaction, otherwise, if we kind of flip gears here a minute, the posterior arch stress reaction is, I think it's actually epidemic in our sports population. And I cover sports for 2 different school districts. And 3 years ago, I had 3 football players on the sideline at one school, and then a volleyball player on the sideline at the other school. And so every year we're facing this as far as back pain in our teenagers. So we've just got to keep this in mind when we have those teenagers come in with back pain related to sport. So this is an example. This is kind of an off the wall example that we got out of the literature, but I think it's fairly interesting. So a gymnast there, and here's a stress fracture in the thoracic spine in an elite rhythmic gymnast case report, just to show kind of an example here. Plain films were not real revealing on this one. And then they got special imaging. Here's the MRI study showing edema in the posterior elements at T11 and T10. And then we can actually, on the reformatted sagittal CT scan, we can see this fracture line occurring in the pars interarticularis region. And that kind of describes or follows what is described in the literature, that those fractures propagate from the inferior medial margin of the pars, and then it moves outward. And then on the axial images on MRI, we can see edema in the bone. And so most of the time, anytime we see edema in the bone in these kids, we know that is a painful bone. So when you push on them there, they're going to be painful right there. And here's the position where this gymnast, she was trying to perform those stretches, and of course the torque or the location of the most stress in her spine then is right in here. And so that's where her stress fracture occurred. And so then with the other differentials here, this Radiology Key website had a good list of differentials that I just thought this was a good mnemonic here. no good comes of a sacral mass. And so different considerations that we could look at are neurogenic tumors like the neurofibromas, schwannomas, and malignant peripheral nerve sheath tumors, giant cell tumors included, of course, chordoma, benign nodal cord cell tumors, and osteoblastoma, aneurysmal bone cyst. And then, of course, we go into these sarcomas with Ewing's, osteosarc, and chondrosarc. And then tumor simulators, like with red marrow changes, Paget's disease, stress fracture, and then METs, myeloma, or the M here with masses, METs, myeloma, lymphoma, and meningoceles, and Tarlov cysts. So in the age range that we look at, so less than 20 years of age range, the benign lesions would be the osteoblastoma, and then we get into malignant lesions with the Ewing sarcoma and osteosarcoma. Then we get into 20 to 40 age range, and then over 40 age range for the list of different pathologies that occur. So even in here in the osteoblastoma, Ewing's, osteosarcoma, that's really what I was concerned about, worried about for this little one before they got the biopsy on her. So here's an example out of the literature of a Ewing sarcoma of the sacrum, and just the destructive pattern here at sacral ala coming in, and it's even affected the ilium a little bit here in an indirect way. Then here is an aneurysmal bone cyst, and of course that is the finger in a balloon type of thin wall, very thin wall on our aneurysmal bone cysts, and the very characteristic fluid levels that layer out, because the blood and fluid products layer out when they lay there on the scanner, so we get these horizontal fluid levels. And then this is the appearance of calcification after they did an embolization procedure on this particular patient. Schwannomas, this is kind of scary. Think of this in the office. Think this is just bowel gas running across this, but no, that's that cortical line that we're seeing here, that shell from an expansile nerve tumor. So it's a nerve tumor in the foramen, and it's expanding, eroding the bone. And that's why we got to have those good plain films so we can pick these things up. Giant cell tumor, eccentric in the bone if it's in a long bone. So again, it's eccentrically placed, ill-defined margins here, and it actually has a soft tissue mass associated with it, and it actually crosses the joint. Here's the chordoma in a 61-year-old male. So anytime we think of a sacrum, and then we go up to the top, the base of the skull, at the clivus, our chordomas are going to be considered to be a possibility in that. So very inhomogeneous tumor matrix here, a lot of soft tissue along with the bone destruction. 17-year-old with an osteoblastoma, which it's the big brother of the osteoid osteoma. So a very painful lesion. It likes the posterior elements of the spine. And so here it is on the axial image down below there, and then on the coronal image in the upper left portion of the sacral ala there as well. So the biopsy on our little patient, it was inconclusive at the lumbosacral junction, and they did a bone scan. I haven't ever seen the bone scan, but they did a bone scan, and there was uptake in the patella. So the kneecap was hot on the bone scan, so they went ahead and biopsied the kneecap, and it revealed Langerhans cell histiocytosis, and that's a whole lot better than osteosarcoma. So Langerhans cell histiocytosis, also known as eosinophilic granuloma, that's a lesion belonging to a group of disorders now classified by the World Health Organization as histiocytic and dendritic cell disorders. Incidence, not very common. Half of 0.05 to 0.5 per 100,000 children per year, and males more predominant than females. Disorder represents less than 1% of all biopsy-proven bone lesions. And let's see, it's a disorder of excess immune cells called Langerhans cells that build up in the body. So we've got a bunch of white blood cells that conglomerate together and make like a tumor formation. The cells which help regulate the immune system are normally found throughout the body, skin, lymph, spleen, lungs, liver, and bone marrow. Langerhans cell histiocytosis, excess immune cells usually form tumors called granulomas. Many researchers now consider LCH to be a form of cancer, but that classification remains controversial. About 80% of affected individuals have one or more granulomas for the Langerhans cell histiocytosis, causing pain and swelling. The granulomas may occur in the skull, the long bones, arms, legs, and may cause the bone to fracture. Other signs and symptoms include swollen lymph nodes, abdominal pain, yellowing of the eyes, and whites, or yellowing of the skin and the whites of the eyes with jaundice, and then delayed puberty, protruding eyes, dizziness, irritability, and seizures. About 1 in 50 affected individuals experience deterioration and neurologic function, which is neurodegeneration, especially those patients that, of course, have the skull involvement. It's often diagnosed in childhood between the ages of 2 and 3, but can appear at any age. Most individuals with adult onset LCH are current or past smokers. About 2/3 of the adult onset cases, the disorder affects only the lungs. Severity of LCH and its signs and symptoms vary widely among individuals. Certain presentations or forms of the disorder were formerly considered separate diseases. So then older forms of eosinophilic granuloma or other forms of eosinophilic granuloma, older names included eosinophilic granuloma. And then we'll get on to, eosinophilic granuloma here of the spine. It causes this classic vertebra plana that we all remember from board exams. And this is about the only type of compression fracture of the spine that I know of that will actually reconstitute itself. So upon healing, we can the height of the vertebra can be reconstituted. Then Hans-Schüller-Christian disease is another multi-system disease, but without risk of organ involvement, and occurs in kids age 2 to 5. And it same type of thing, skull, the flat bones of the body, the skull, ribs, pelvis, and the scapulae. So the flat bones of the body are the preferential sites for Hans-Schüller-Christian disease, and that gives us this punched out appearance. And they talk about a beveled appearance, so it'll be a hole within a hole appearance in some of them. That one really doesn't have quite that appearance, but that's what they describe. Litter-Seewee disease is a more serious disease. It's kids under 2, and it's a higher mortality rate for these kids. They do have multi-system problems and anemias, thrombocytopenia, and those are bad things that will lead to the demise in those cases. Supportive treatment for Langerhans cell histiocytosis, hormone replacement therapy if they've got hypopituitarism, and also diabetes insipidus is found in those patients, or can be. Chemotherapy, and that's how our little one was treated, was with chemotherapy, and she is now in remission. And so she's doing well. She's back to riding a bicycle and doing some other things and pretty active. Sometimes surgery, corticosteroid injections, rarely radiation therapy, but for a unifocal or single focus of bone involvement. Because the syndromes are rare and complex, patients are usually referred to institutions with experience in treating them. So then we have to send them up to like Kansas City or other places where they'll get more cases involved, or they've seen more cases. Prognosis is good. If the disease is restricted to skin, lymph nodes, and bones in age over 2 years of age, again, morbidity and mortality increase if they're under 2 years of age, and they have other involvement with hematopoietic system, liver, and spleen. And with treatment, overall survival rates for patients with multi-system disease without risk of organ involvement is about 100%. So hopefully that's a whole lot better news compared to an osteosarcoma in the sacrum, which is what I was afraid she was going to have. Differential diagnostic consideration with children and adolescents with back pain, again, stress fracture. It's probably the most common type of pathology if you consider it a pathology that we see in this age group in the spine. Of course, if we're looking at those kids, then manipulative therapy is not going to be indicated in the active phase. We need to have them immobilized, And actually, we're shutting these kids down for about 12 weeks on these stress fractures now with back bracing for about 23 hours a day. So we must keep this in mind when working with adolescent patients. Our patient was younger, and she is in the pre-adolescent range. And so again, different etiology of pain. We got to maybe think about that. Infections and those other types of etiologies. Okay, next case. The new mom here, she was a 26-year-old female, 6 weeks postpartum, when she presented to our office with back pain. She's got a healthy infant, back pain of a couple of weeks duration prior to presentation, pain with bending, lifting, increased pain with standing from sitting position, no recent falls, no lower extremity symptoms. History is positive for a mini stroke when she was age 21 from birth control, but she didn't have any neurologic residua after that event. Back pain was significant enough that when we did try to position her after the exam to try any side posture stretches, she could not handle that at all. Flexion distraction type motion on a Leander table, she could not tolerate that at all. So some passive therapies and light stretching were attempted. And it was about a 3-week duration here. She went out of town for a bit. I had to go out of town for a bit, and we get back together, and she's still not feeling well. And I'd already gotten plain films on her in the interim, and then MRI was then ordered. So plain films are the starting point for our back pain patients. Advanced imaging may be indicated through patient symptoms and clinical signs. Of course, MRI, CT, ultrasound, not really spinal imaging, of course, but radionuclide bone scan, contrast studies, and then mammography and DEXA. And so she needed a DEXA actually at the end of this thing. But so here's her plain films. This is kind of a spot view. I've got a better picture of the upper lumbar area later on in the slide, but I tried to cone down on that for the photo. So it's a little bit overexposed, but so then they think, well, is that osteopenia? But otherwise, the height of the vertebrae pretty well preserved. There's a little bit of subtle superinflate depression in there, but is that just notochordal persistency, normal variant? No cortical disruption on the anterior cortical edge like we would want to see for a compression fracture. A little bit of a spinal lean, slight iliac crest height discrepancy maybe. She's got maybe some sclerosis that could be with it being real bright there, that could be projectional and technical. But so anyway, no evidence of a overt fracture. Pedicles are all intact. Alignment otherwise good. So no evidence of fracture or dislocation. Vertebral body height's preserved. Lordosis reduced. Slight right lateral lumbar list. Sacroiliac joints preserved. Osteopenia, technical or real. We got to have 30 to 50%, lots of bone density to see it on a plain film. Due to the continued pain and inability to move, bend or lift without pain, we got MRI ordered. And then lo and behold, here we go. Here's the T1 weighted image, fast spin echo T2. Then on the right is the inversion recovery. So when we come up and look at these, there's low signal intensity in the superior portion of the vertebral body of L5, a little bit in L4, and at L1 with low signal. And we can see superinflate depression on these compared to the normal levels of L2 and L3. And same thing over here, depression and edema. So we've got increased signal at the superinflate, subtle increase in signal, and increase in signal here at L5. And then we go to the inversion recovery, which really shows fluid as bright white and shows sub-Q fat as nullified. And sub-Q fat is brighter on the fast spin echo T2. So now we're differentiating fat from fluid on the inversion recovery. So we've got edema at L5, L4, and L1. So this is acute compression deformities in a 26-year-old. So the T1 weighted lumbar MRI here compared with the X-ray appearance, and those superinflate depressions, we can easily see them on the slicing through the region with the MRI, and we just don't pick it up the same on plain film. I mean, we wouldn't be running imaging on everybody if we tried to guess if there's superinflate depression on these from the plain film. So slicing through it makes a big difference for that. Superinflate depressions, we already mentioned that, so I'll skip on through that one. And then our signal alterations, as I mentioned before as well, decreased T1, increased T2, and increased inversion recovery. So plain film findings, osteoporosis, vertebral body heights preserved, MRI, super-end plate depressions, edema at the sub-end plate zones, findings consistent with, just like an osteoporotic compression deformity. So then we go back and talk to the patient again, and the only medications that she listed on her intake form into the clinic was prenatal vitamin, and that was it. And she had stopped taking any other medications prior to coming in to see us. And so we talked with her about, what other things could she have been doing or taking that would have caused osteoporosis. Well, pregnancy in and of itself is a risk of osteoporosis, other medical conditions, and then of course medications. And then you look at, do a little search, and you go common medications for causes of osteoporosis, and the list gets pretty long. So of course steroids, obvious, breast cancer drugs, prostate cancer drugs, heartburn medications, proton pump inhibitors, and aluminum containing antacids. Those can both cause decreased bone density. Depo-provera contraceptives, excessive thyroid hormone replacement therapy, anti-seizure medications, mood-altering drugs, Tegretol, Dilantin, diuretics, of course, prostate drugs, anti-rejection medications, heparin therapy, blood thinners, chemotherapy drugs, SSRIs, selective serotonin reuptake inhibitors, and diabetic medicines, insulin sensitizers. These can also all result in decreased bone density. So when we talked with her further, we find out that during her pregnancy, she was treated prophylactically to prevent a second stroke that they were worried about during the pregnancy. And so she was treated during pregnancy with heparin and also a low molecular weight heparin alternative, which is called Lovenox. So she had used both heparin and Lovenox, and she had stopped taking any of those things prior to coming into the office, so she didn't put those on the history form. And black box warning for Lovenox. I use Hippocrates in the office. If somebody's got quite a list of medications, we can go to the app called Hippocrates, and it gives a good list of contraindications of multiple medications or interactions between medications. And it's a free app that you can put on your phone, and it's kind of handy to have that. But it's interesting, this black box warning comes, and of course she didn't have an epidural steroid or injection at any time, but just the when you see the disclaimers at the end of the TV commercials for medicines make you not want to take the medicine anyway, right? So same type of deal. Okay, here's a spot shot of that upper lumbar area. So here's the L2 level on the plain film, 5, 4, 3, 2, and 1. So here's 1 and here's 1. So again, no overt compression fracture. I just kind of worried myself, what did I miss when you get the MRI back, and then you got to go back to your plain film. It's like, wait a minute, what did I miss? So here's an article on low molecular weight heparin induced osteoporosis and osteoporotic fractures, a myth or an existing entity. And this is from 2010. And I think, well, I think we can say it's an existing entity, I think, especially when you add it to the risk of osteoporosis with pregnancy by itself. Another article from 2005, minimizing the risk of heparin-induced osteoporosis during pregnancy. And we sent her back to her medical doc and the OB about this, and I've kind of got a cold response on this. They didn't seem like they wanted to really admit that they, knew that was going to happen. But she healed up over this pretty well. We didn't, of course, we didn't treat her anymore, and advised nutrition and stuff. And then I found out she did have she has 2 little babies now. And so she's done well after that. Her second pregnancy, she did not take any prophylactic medications and did good. So the question I had, I guess, during this when I was looking at my films is, what did I miss on the initial films? So you go back and look at them, and the MRI is just more sensitive to disclosing those anatomy changes because of sectional imaging. So vertebral compression fractures, end plate depressions, Smorl's nodes, all those show up a whole lot more conspicuously when we slice through them on the MRI. So plain film just isn't, that sensitive for that type of evaluation. So a couple extra cases here, another 54-year-old female with back pain, and we have a subtle compression fracture here, super end plate depression, and a little sclerosis in the sub end plate zone, very slight trapezoid configuration. We can catch that's the last rib down here is T12, so that's T11, and we come up here T12, T11. We can see a little sclerosis and end plate depression here, and then so is that, to me, that looks like a fairly newer one with the sclerosis there, but it's always hard to decide, is that new or old when we look at those. If they're painful right there, then I think the next thing we need to do is we need to get an MRI. And then this is, I think that's just an hemangioma. The level we're talking about is here. And so this is T2 weighted sagittal image, and we can see the super end plate depression there better than we did on the plain film, and a little sub end plate zone of edema there. So it's probably acute compression deformity. T1 weighted image fluid is going to be dark, so it's a little bit more wide, darkened zone there compared to the other end plates. So I think we do have some little edema there. And then on the inversion recovery image, this was a more low field unit. The institution where I read films at now, they've replaced this MRI unit, so we're getting much better inversion recovery images now. They've got a high field unit in there now. But here's our edema and our super end plate depression again here. So this is acute compression, acute or subacute compression deformity. And of course, we would not want to do much, do any manual maneuvers on that, and that person needs to heal. So, we get these two patients, or the first patient initially, especially her, she'd been to her other provider and for pain that lasted for quite a while with no imaging. And then of course, now we're going to potentially do some manipulation on that person when they come to our office as our main tool of therapy. We've got to have imaging. Then here's a 9-year-old boy with a headache. And there's a confusing history in this thing all the way through from the referring doctor that sent me the films. But anyway, possible fall from the tree a month ago or up to 6 months ago. So he's had a headache off and on for a long time. And the pediatrician has gone to the MD and the ER. Pediatrician visit for the headaches, but the pediatrician did not want to do a CT scan because of too much radiation exposure for one CT scan. And the patient, parents brought the patient to the DC that referred the films to me, and he took plain films of the neck, and it looked like C1 was rotated badly, but actually it's because this kid, in order to just sit up, he tucked his head and chin down, and so his head was cocked in a funny position just sitting up because his head hurt so bad. And so then we said, well, let's get it. If I reviewed the films, I thought it was mostly rotation, and I don't have the plain film, sorry. But I said, let's get a CT of the neck then, and we'll see what's going on. And when he ordered the CT of the cervical spine, then they also ordered, he said, well, let's get the brain too because of his headaches as well. And here's what they found. So there's a big cystic tumor in here pushing his brain tissue over. And this kid's been sitting on this for several months duration. And his parents have begged, imaging, but I don't know, besides the quote unquote term radiophobia, just being scared to get an image on a kid, then they didn't perform them, and this little boy's suffering all the way through this. So these are differential diagnostic considerations for that type of a brain lesion in this age range of kid, and not common, but just devastating. So when we look at some of these things, think, okay, what's the medical legal manifestations or implications? And missed or delayed diagnosis into some of these things. Of course, it could have been devastating on that last one. And considerations for malpractice. So this is kind of more towards, I guess, us radiologists, but it also goes for you. If you're reading your own films, dictating your own report, you're acting as a radiologist. And in some courts, you'll be held at the level of a radiologist because you're acting as the radiologist. So sit down and read your films in a quiet location. The reason we miss, so perceptual errors and negligence is the name of the paper there. And so errors of perception, 70 to 80% of the reasons for missing findings. We just don't see the finding, even though it might be there. And so that's kind of like the car wreck scenario. You have 5 people standing on a street corner and they see 2 cars crash. You go to each of those 5 people, they each saw the crash, but they'll describe different crashes. And that's that perception. So we have to limit our error in perception as much as we can. Cognitive errors is what we do when we do see the finding, but we ignore it because we don't know what it means or attribute it to something else. Kind of like that nerve tumor in the sacrum that we saw earlier. Was that a bowel gas fold, or was that a real deficit in the bone? So with respect to mistakes or errors in radiographic diagnoses, some are cognitive, that is, they result from a misinterpretation due to lack of knowledge or faulty reasoning. Perceptual errors, on the other hand, in which the radiographic abnormalities are simply not seen by the radiologist on initial interpretation, are a far more common cause of radiographic mistakes, accounting for as much as 80% of them. So missing an overt lesion remains as much a mystery and enigma as today as it was 50 years ago, according to this article. So failure to detect a radiographic abnormality is often attributed to the subtlety of the radiographic finding or its poor conspicuity, a term defined by these authors as the ratio between the contrast enhancement of the lesion or edge relative to the surrounding tissues. So if we got good contrast, it's like a bone island in the middle of a long bone, you got lower density bone around it, and this big bright bone island, we're going to see that it has high conspicuity. While this definition may adequately explain how a true subtle lesion can be missed, it's woefully inadequate to explain how an obvious abnormality can be missed. And I hate to admit this, but when I was a resident, I was dictating a report, and our chief, Dr. Conley, comes in the room, and he just blipped in, see how I was doing. It was the end of the day, I don't know, 6, 7 o'clock or something. It was late. And he said, he just barely looked over. You did mention that mastectomy, right? And then he turned around and left. And I'm like, oh my God, my blood went out of my head, and I'd missed that there were, anyway, mastectomy changes on the film. But that was a good, I guess that's what the residency is for. Anyway, so when we read films, it's like a Where's Waldo situation. It's a fresh look at the picture, and you have to find Waldo. So let's think of some, so if somebody knows where the lesion is, a malpractice case, and then they say, hey, this is a malpractice case, look at this, can you look at these images? I already know there's a problem with the images, right? So I'm already ahead of the game compared to that. But of course, hopefully clinically, you know where your patient's pain is, and then we go from there. But so reading images cold, without much history, without much information, it's a total Where's Waldo, and we have to look and look and look to make sure we find him, find everything going. So here he is right here. Of course, now that we've seen him, just like in a court case, the attorney can come up and say, hey, or the expert witness can say, hey, there it is. We can all see it. You missed it. Like, now, wait a minute, So that's the thing with coming through this. And there he is. He got a little backpack on or his knapsack on. There's Waldo. So we can overlook them. Let's see. See similar appearing figures. So that's that low conspicuity. Once Waldo is found, going back to find him again is easy. Just as going back on an X-ray, knowing where the abnormality is, then it will be easily seen. So radiographic interpretation is not practiced retrospectively. We must be able to discover Waldo on the initial reading. Several factors affect our interpretation and accuracy: interruptions, phone calls, patients, and any other items that are concentration breakers. So if you've got the TV or YouTube blaring in the background, take time to sit down and actually look at your patient's films and be careful. Additional factors that result in errors in diagnosis: not getting imaging in the first place, kind of like we saw with a couple of these cases. not getting the right images or incomplete series, or images of the wrong body region. So again, sacrum, lumbar spine, or maybe it's foot and ankle. We need to make sure we get the images that are going to cover the anatomy that we need to see for diagnosis. Technical problems, bad films. If you've got digital images and you're getting funky digital processing artifacts, you need to stay on your vendor to get those images ironed out. You should have good quality digital films coming out, and they need to help you with that. Plain films and digital processing errors, as I mentioned, help have your vendor get through those with you. Patient body habitus, if it's a really big patient, maybe they need to be laid down on a table, then we need to send them out for that if you don't have a table. Overlying artifacts. I saw a picture the other day of earrings that were little bicycles, and they covered up most of the cervical spine on the lateral view. Just simple things. Get the overlying artifacts off the patient's anatomy. Patient positioning errors, upright bucky for an ankle study. So we put in a digital upright system, and then now we're throwing up an ankle up in the air to look at those. The anatomy is distorted, not the best scenario. So please, do your due diligence and get these studies done properly, so that we can see the anatomy the way it's supposed to be represented. Perceptual errors and negligence, another article. This is pretty old. 15-year-old male, 1 week of pain, saw his primary care doc, ordered an x-ray. It was read normal by the radiologist. They prescribed anti-inflammatory medicines. He had 3 weeks of pain continued, referred to an orthopedist. The orthopedist diagnosed patellar pain syndrome. I don't think he got any new x-rays, changed to anti-inflammatory medicine, and he prescribed exercise. So 5 weeks later, total of 8 weeks of pain, the patient fell riding his bike. Now he had a comminuted distal femoral fracture. They applied a plaster cast, continued pain for 4 weeks, and then they removed the cast due to swelling. And now they found a tumor, an osteosarcoma, ended up in a leg amputation, and the family sued due to misdiagnosis on the x-rays. And supposedly, this was the initial plain films, and supposedly there's a radiolucency in the bone here. And I can't decide, there's normal radiolucency here above this is the top, the roof of the intercondylar notch right here. This is growth plate, the physis here. So there's kind of a normal radiolucent region there, but the article says there's a radiolucency in the metaphysis. So that would be in through here, above that. And I would miss that, I think, every day. So this went to court, and actually the judge, maybe not so great for the patient, but the judge did find in favor of the radiologist and the orthopedist that that lesion was just too inconspicuous to be detected on plain film. It was probably there on an MRI though, if they would have went further and did some advanced imaging. So correlation of history and clinical findings with physical exam to determine the need for imaging. If manipulation is contemplated as a treatment method, then imaging may be indicated. Pain severe enough that a patient cannot bear weight, then imaging may be needed. Night pain, pain with rest, fever, overt trauma, visible deformity following trauma, of course, and repetitive trauma, I'll consider imaging. Out of Dio and Dale, this is the group that they commonly quote for the guidelines on reasons for imaging for back pain. So patients over 50 years of age, and I would add that other researchers have said under 20. So that 20 to 50 age range is kind of the group that mechanical back pain hits very frequently. That's going to be the toughest one. You want to make sure you have your red flags in order for those. Outside of that 20 to 50 age range, we're looking at different pathologies. So significant trauma, neuromotor deficits, unexplained weight loss, suspicion of ankylosing spondylitis. That hits every male above age 15 or 13, right? Drug or alcohol use, use of cortical abuse or corticosteroids, history of cancer, fever, recent visit within a month for the same problem, no improvement. So watch that for sneaky progression of a disorder, and patients seeking compensation for back pain because they have to have a kind of a baseline evaluation of the spine for degenerative changes, etc. So do your own work, take a good history and exam. Even if the patient has been to another provider, maybe they didn't do a good exam, and It's kind of sad to say, but we see that too often, and or the patient's condition could have changed by the time they come into you since they've seen that other provider. Order or get imaging when indicated, get quality radiographs so that you can make your determination from a good film, and careful attention to detail in your history, exams, and review of imaging, and don't get hung up on guidelines or radiophobia. And I think that is the end of my presentation.
All
Welcome
right.
back to Mike.
Thank you very much, Dr. Gould. Appreciate it. I'm going to take the screen back here, so bear with me just a moment. Okay, we did have one question come in that I wanted to put out there. It says, when do you consider a bone scan in the adolescent with a suspected pars stress fracture?
Actually, right now, I've been jumping straight to MRI. There's no radiation exposure with MRI. It's easily repeatable, so you can do it follow-up if you want 12 weeks later. And with bone scan, they've got to get a dose of radiating, the technetium-99 is radioactive. They've got to urinate that out, so it's getting their kidneys and their bladder, gonads, for radiation exposure. And you don't want to do a bone scan, you would have to do a SPECT bone scan, which gives you the 3D slices. So, and then it's still not very good anatomical detail. So MRI is definitely the preferred modality to look for active PARS or active posterior arch stress reaction in teenagers, and go from there. And then also, you can also see soft tissue, the disc, and then other anatomy. The SPECT bone scan has a little more detail, but it's still not a detailed exam compared to a CT or an MRI. So I guess I wouldn't consider a bone scan for a teenager unless I thought they had multi-system disease, like our little 8-year-old. She had a knee that popped, that had a patella that popped, and then you're looking at a whole nother category of disease if they've got multi-bone involvement.
Okay, all right. Well, that's about all we have time for today. So thank you, Dr. Gould, and thank you to our listeners for joining us. We hope you found the information informative. As we wrap up here, I'd like to remind you of our next webinar on April 15th at 12:30 Central Time, when we're going to be talking to Dr. Kelly Humphreys about sports chiropractic. Also, remember our resources section on ncmic.com. We are continually adding to our content with information to help you navigate daily practice and deal with the challenges that you face. We have information out there on a wide variety of topics, including COVID issues and risk management. So please check that out. I'd also like to remind you of our podcast, Chiropractical. The podcast provides great information for your practice, so check that out as well. A new episode is now available. We put those out every month, so you can find that podcast at ncmic.com or wherever you get your podcasts. You can also keep up to date with new resources from NCMIC by following us on Facebook, Twitter, Instagram, and LinkedIn. Once again, thank you for joining us, and from all of us at NCMIC, hope you have a wonderful rest of your week.